Scott.
Good morning, my lady. May we please call Professor Fu Mengko?
I do solemnly, sincerely and truly.
I do solemnly, sincerely and truly
Declare and affirm.
declare and affirm
That the evidence I shall give.
that the evidence I shall give
Shall be the truth.
shall be the truth,
The whole truth.
the whole truth,
And nothing but the truth.
nothing but the truth.
Good morning, Professor. Can we have your full name, please?
Fu Mengko.
And you are here today to give evidence on behalf of Public Health Wales. Is that correct?
That's correct.
And can I just ask when you started working for Public Health Wales?
On the 1st of June 2021.
And prior to that, what were you working as?
I was working in Public Health England as the Centre Director for the East Midlands and subsequently as the National Programme Director.
And since June 2021, what has been your role within Public Health Wales?
I am the National Director for Health Protection and Screening Services and the Executive Medical Director.
Thank you. Just a brief outline of the role of Public Health Wales. So part of the responsibilities are maximising the use of digital data, research and evidence to improve public health. And also part of Public Health Wales' responsibilities is it's a Category 1 responder, as defined by the Civil Contingencies Act, and therefore plays a key role in relation to the preparation for and response to any emergency and major incident. Is that correct?
That's correct.
So there's very much a future-looking, data-driven element to the Public Health Wales. Is that right?
That's correct.
At the start of the pandemic, did Public Health Wales actually have all of the data and the surveillance that it required in order to be able to track cases of COVID-19, hospital admissions, or did it not?
So at the start of the pandemic, we were building on the surveillance of communicable disease processes that we routinely have, and that includes monitoring cases of infectious diseases and particularly spotting clusters and outbreaks of communicable diseases so that we can take early interventions to control further transmission. With respect to hospital infections, clearly anyone who had a laboratory test with a result of infectious disease, we would collect as part of our surveillance.
Yes, but were you able to get, well, let me do this a different way. Can we please have on screen INQ 000 409 575, it's page 4, it's paragraph 13. So this is the Public Health Wales statement. And up until 24th of March 2020, NHS Wales had few reports flowing out of our laboratory system on staff and patients who had positive COVID results. Apologies, this isn't the Public Health Wales statement. This is a let's find the correct reference.
No, we take your time, Scott.
This is a statement of Andrew Nelson, Chief Information Officer at a health board. Mr. Nelson there sets out that up until the 24th of March, NHS Wales had few reports flowing out of the laboratory system on staff and patients who had positive COVID results. So in the early days, admission volumes was left to text mine, free text fields from the emergency department. And that was relied upon to provide a record of who had been tested and what the outcome of the test was. The absence of this information meant that during March we had limited access to prevalence and admission data from which we could monitor or estimate growth rates and to provide an effective operational response. Now, if that's the Chief Information Officer at a health board, is that unique to the health board or does that also apply to Public Health Wales?
So let me set out the position as I see it. From the 1st of February, Public Health Wales undertook laboratory diagnosis of COVID-19 and made this test available across Wales through its network of laboratories. And any test coming through that system is reported on the LIMS system, which is mentioned in this statement, which is the Laboratory Information Management System. And the results of that would have been available to all health boards.
So, did Public Health Wales have the tracking of all of these cases? Because if it was not available to this health board, which seems to be the implication, particularly that final sentence of paragraph 13, then how was it available to Public Health Wales?
So we have access to LIMS in the same way, but obviously we have direct access to the outputs of our own laboratories. So we had access to the information to collate information about COVID positive test results. And that information would have been also available to health boards at a local level. Now, we collated the information in our surveillance reports and through a variety of mechanisms, whether it was publication of the daily dashboard or sharing information at weekly meetings of our surveillance outputs, we were able to share the outputs of the surveillance of COVID-19 throughout the pandemic.
So you were satisfied that you were able to track, when I say you, I mean Public Health Wales, were able to track all the cases that there were in Wales from February 2020, is that right?
That's correct.
And were you also able to track because if we just go on to paragraph 15 of this statement, which is just over the page, thank you. So a further implication arising from the design of the hospital element of the record was that data is not available to WG, presume Welsh Government, NHS Wales or others at a coded data level until clinical coding 3 months post-event, unless the patient went to theatre. Subsequently, there was limited ability to use the data to monitor and analyse who was receiving what level of care, assess whether someone was admitted due to COVID or whether it was an incidental finding, and assess how outcomes varied dependent on care pathway and treatment decisions. Are you satisfied that Public Health Wales did have all of that information?
So Public Health Wales has access to information that allows it to link up several information sources. So hospital episode statistics means that we're able to then track when a person was admitted to hospital. And by linking it with data sets about the test results, we were then able to say when the hospital admission occurred in relation to the test result to make assumptions about the acquisition of infection, whether it was community onset or hospital onset. And we published reports of those outputs.
That's not quite what this paragraph's touching upon, though. Is those 3 bullet points there, is that type of information that Public Health Wales would have sought to gather?
So we worked very closely with Welsh Government through the Health and Social Services Group, Planning and Response Group, that had an overview of NHS planning and response throughout the pandemic. And we provided epidemiological reports on the surveillance of COVID occurring, whether it was in the community or in the hospital. And the level of information in this statement talks about clinical coding and outlines some of the challenges in having official results of the level of care that an individual receives in hospital. That wasn't in the direct remit of the surveillance function for Public Health Wales on monitoring communicable diseases.
So the answer effectively is this isn't something that Public Health Wales needed to know.
It wasn't our direct responsibility to report on the level of care received by patients in hospitals.
Yes, but in terms of your levels of responsibility, when you're in the middle of a pandemic, roles, remits, areas of importance can slightly shift compared to non-pandemic times. Is that fair?
That is fair, but we clearly have to prioritise against what we had the expertise and capability and capacity to do, which was the surveillance of communicable diseases.
Right, so the surveillance of diseases, did that take up all of Public Health Wales' capacity then?
No, it didn't. We were also there to help with the control of transmission through investigation of outbreaks. We also established whole genome sequencing and used that to understand the transmission of the disease.
Okay. So these elements here that we can still see on the screen, those are aspects that fall outside of Public Health Wales' remit, and is there evidence that actually they shouldn't have fallen within Public Health Wales' remit during the pandemic at all?
Not entirely. So assessment as to whether somebody was admitted due to COVID or whether COVID was an incidental finding was absolutely within our remit, and we did publish nosocomial transmission reports to that effect.
Just want to come back to the reason why I was looking at this. You have an information officer from a health board who's talking about a lack of access to what seems fairly fundamental data. Do you agree with that?
That is what I read in this statement, yes.
And if Public Health Wales is looking to make sure that it was having access to the relevant data in its role as maximising use of digital data to improve public health and as a responder for a major emergency, a major incident, is making sure that boards have access to this type of information something that Public Health Wales did do or should have done?
We contributed to the thinking and the planning and worked directly with the Welsh Government Health and Social Services group.
I'm sorry to interrupt, Mr. Scott. Can I just go back a step, Professor? And it's probably a different point from the one that Mr. Scott is pursuing. To carry out a surveillance of the spread of COVID infections in Wales, you need to survey how many people are positive in the community, how many people are positive in hospital admissions.
That's correct.
How widespread was testing at the time that we're talking about in Wales?
In the early stages of the pandemic, testing was very limited because of the lack of availability of testing kits and testing platforms at the time, and there was a huge competition for these across the globe. So we had to prioritize our testing for those who needed it most, and mostly it was testing to diagnose.
So in other words, your data is coming from positive tests in a hospital or healthcare setting?
Mainly because these were symptomatic people who were admitted hospital, and the case definition at the time was that they had to be fulfilled before a test was requested.
So the data you had at time would have given you virtually no idea what was going on in the community?
Indeed.
Right.
Should you not have found a way, or should you not have planned to make sure that you did have access to that information prior to a pandemic?
But we rely on testing activity, and if there was limitation in the testing activity, there was no way of ascertaining whether or not someone in the community indeed had COVID.
Talking also about the surveillance, and you're talking about causes of death in your statement at paragraph 109, and the form was created, and it's described as saying, throughout April 2020, Public Health Wales, DHCW, the Welsh Government and health boards worked together to construct an electronic reporting form. So that was the form that was then used in order to provide key information about deaths. Is that correct?
That's correct.
If we can have that on screen, please. That's INQ 000276009. So this is the form that was created.
That's correct.
Why was it that it was only throughout April 2020 that work was being done on creating a form such as this, rather than being done at an earlier stage?
So there were systems of notification around deaths occurring in hospitals at the beginning, but it transpired from early experience that this wasn't reliable. So we wanted to put in place a consistent method of rapid surveillance of mortality occurring in hospitals. And on the 23rd of April, this was implemented after discussion with the Chief Statistician at Welsh Government and also in liaison with the National Wales Information Service.
You said it was transpired from early experience that this wasn't reliable. When did you realise it wasn't reliable?
I think there was a document summarising some of the challenges in existing systems. There were multiple routes of reporting. Some relied on official information through the ONS with a data lag of 10 to 15 days, which at the time was not acceptable because we wanted a rapid surveillance system to indicate the trends in mortality occurring in hospitals.
Yes, but the question was, when did you realise it wasn't reliable?
Very close to that time, in early April.
And so early April you realised it wasn't reliable, and then it was on the 23rd of April when this form became widely used, is that correct?
It was implemented on the 23rd of April with the communication from Dr. Andrew Goodall, who was the Chief Executive of NHS Wales and Director General of the Health and Social Services Group. And in the email, there were signposts to guidance documents on how to complete the form and a training video that we prepared.
So if it was implemented on the 23rd of April, from what point in time are you satisfied that the information that you were gathering via this form was accurate and was a complete representation of what was happening in hospitals?
That's a difficult question to answer because throughout the pandemic, it was clear that there were elements of the form that were not as well completed as they might be. And there was missing information, for example, in the 6,514 deaths that had been registered throughout the life of this form. There were over 1,000 elements of missing data in the question around key worker status, for example. So we couldn't reliably report on some of the elements in this e-form.
What did you do? Because you generated this form in April 2020. It clearly contained information that was required by Public Health Wales or other bodies. What did you do to make sure that it was accurately completed? Because it was all necessary information.
So there were weekly meetings at the outset with all the health boards, with clinicians from health boards, particularly through medical directors. And my predecessor and the chief statistician for Welsh Government co-chaired these mortality meetings. And that was an opportunity for improvements in reporting using the e-form. And, you know, the e-forms are completed often not by a single person in each health board and was shared amongst the clinicians in the health board reporting the deaths.
I just want to look at one line at the bottom. I think it was highlighted earlier on. If we could please have that highlighted again. It's the highlighted line, was the patient a key worker? And there are 5 different buttons that can be pushed, one of which is a healthcare worker. So it was intended when this form was created, was it, that you'd be able to flag up whether somebody who died was a healthcare worker?
That's correct.
In your statement, at paragraph 126, it says, we do not hold data in respect to the number of staff within healthcare settings in Wales recorded as having died of COVID-19. This is because the occupation of cases was not recorded on most laboratory reports or rapid death reports. How is it that you weren't getting the information that you required from this form?
As I said earlier, there was a significant element of missing data in this particular question, about 17% missing data, where we were able to collect information on healthcare worker status. I think there were 36 responses to affirm the status as a healthcare worker, representing 0.6% of the mortality reported.
It was very important information that you have an understanding of who the staff were who were dying of COVID-19. Is that fair?
It is an important aspect of our surveillance, and clearly this had to be understood in the context of the denominator as well, and this is information that we don't usually report on. So the denominator of healthcare workers in Wales. Yes.
But it was a question that was included in the form specifically for the purpose of capturing that data. Did you think to make it... There are ways when you complete electronic forms that you actually can't submit the form unless you've answered a question. Did you think that that should have been done for that question, so that you made sure that every form included that information rather than a 70% gap?
That is a possible improvement that we would consider in the future.
Is there any other improvements that you can think of to capture the data about deaths or infections of healthcare workers in Wales?
I think there's more we can do in the future, and I think the mechanisms we put in place were intended to improve the quality of reporting, and we could have done more to continuously improve it throughout the pandemic.
Can I just ask a question? Sorry, I'm interrupting all the time this morning. Going back to, you could consider a form that you could only submit the information if you completed all the boxes. But can I challenge that? I mean, I appreciate it was put to you by Mr. Scott and you accepted it. But wouldn't it be more important to find out how many people had died of COVID? I mean, obviously it's important to find out their status if you can. But wouldn't you rather get the information even with the incomplete boxes?
There's always a balance between having a robust method for collecting information that might take a lot longer, And at the time, as you can imagine, it was a pretty difficult time for everyone. And filling a form like this might be one of many things people had to do. So the purpose of this surveillance wasn't to provide a comprehensive capture of information, which there are official statistics that do that through death registration that are more robust and more defined. But this was a very rapid surveillance method for capturing mortality, which was the primary purpose of this.
Can I move on to understanding of ethnic grouping, please? That document come down, thank you. Did Public Health Wales have access to sufficient information about the various ethnic groups that people fell into when they were testing positive with COVID?
So in order to have data on ethnicity, we rely on information from either the requester of the test or information available on the so-called Master Patient Index available in Wales, which has all the demographic information collected at the point of entry into the NHS. And this routine data allows us to understand whether ethnicity plays a role in a whole range of outcomes, not just around COVID. So we had access to that information. The reality is that for the laboratory reporting forms, this data was typically not available.
Why was that?
That's because it wasn't completed if requested. And often this would rely on a requester making assumptions about ethnicity and putting it on the request form.
So when you say making assumptions, can you just expand a little bit about how someone was making assumptions rather than recording information?
So recording information about ethnicity will require someone to designate an ethnic group to an individual. If they don't have direct access to that individual, for whatever reason, maybe they didn't have capacity at the time of taking the sample, then that field is often not filled in.
Was there any guidance that was given by Public Health Wales to those who were taking a sample to say, we need to make sure that you're recording these various categories of data?
There wasn't specific guidance, no.
Do you think that should have been issued?
I think we relied very heavily on routine systems for data collection, and if it's not in the routine system, then the extra steps we take might not have been adhered to, despite guidance.
Again, I come back to a question I asked earlier on. When you are looking for that extra information beyond the routine systems, you're asking that information for a reason. And therefore, is it not incumbent upon Public Health Wales to do what they can to make sure that they are getting as much of that information as they can? Won't necessarily be perfect, but you have taken all steps to satisfy yourself. You get that information you need.
So our preference would be to rely on the data available through routine registration of a patient and individual in the NHS. And that allows us to have a consistent ethnic designation for any individual and allows us to define, therefore, the denominator.
Because if I can please take you to INQ 000224048. So this is page 11. I wonder if we could go to page 1, please. So this was a rapid analysis of ethnic variation in COVID-19 outcomes in Wales using ONOMAP, a name-based ethnicity classification tool. And this is dated the 24th of May 2020. Could you please explain the reason why ONOMAP, which is a software package to classify ethnicity based on names, was used rather than the access to the information that you actually had on the systems about ethnicity?
The system that we had access to, where information around ethnicity on individuals is stored, didn't have a very good completion rate.
What was the completion rate?
I understand it's about 40%. So for 60% of individuals across Wales, we didn't have information around ethnicity. So
just pausing there. From a public health perspective, can you draw any conclusions if you're missing important information about 60% of the population?
I think it depends on what you're investigating. So statistically, you would undertake a power analysis to understand whether a gap in the data of that proportion will have a bearing on the findings of whatever you are studying at the time.
When did it become apparent that there was a 60% gap? Was it at the start of the pandemic, or had it been known prior to then?
I think it'd been known generally prior to that the capture of ethnicity data is not good.
Has any steps been taken to improve that capture?
So one of the things that came out is the First Minister established a BAME advisory group, recognising the disproportionate impact on Black and Asian minority ethnic groups in Wales. And one of the elements of the recommendations and the report published in September 2021 was for work to be done to improve the capture of ethnicity data in the NHS.
How's that going?
I can't comment. I'm not in a position to clarify what the process is undertaken, led by Welsh Government.
Okay. Is Public Health Wales involved in that programme then?
It is.
So then just coming back to the on a map assessment, this was, is it fair to say this was the best that Public Health Wales were able to do to provide an understanding of ethnic variation of COVID-19 in Wales by using ONAMAP?
We had experience of applying ONAMAP to other infectious diseases and understanding of bloodborne viruses prior to the pandemic. So it was an opportunity for us to use this to develop understanding about SARS-CoV-2 at the time. And we were proactive in this regard and obviously shared our findings of the initial assessment with the relevant decision-making groups, including the First Minister's BAME advisory group.
And there are difficulties with ONAMAP, is that fair to say?
That is correct, and the strengths and limitations of the software are discussed in the final published article.
Yes, and I think if we can actually go to that, it's 276032, and it's at page 8. This is, I think, the published article that came out in the BMJ. Is that correct?
Can you give me a tab reference, please? This is 11. That's correct.
That is, yes. And so this is the table of effectively the difference between the ethnicity that was reported and the ethnicity that was predicted. And I think to summarise it, it was recognised that ONAMAP has a habit of overestimating the white population, and in particular underestimates the black population. Is that correct?
That's correct.
And so you can see there in particular that the ethnicity reported by the participant of black or black British is 377, and ONAMAP actually predicted 143. So less than half. How useful was this tool to be able to allow you to have an understanding of the impact of COVID-19 on ethnicity if the tool that you're using has not a hugely successful rate of identifying in particular black or black British ethnicity based solely on their names?
There are limitations in using the software, and you've talked about some of these, and the rest are in the published article. So in terms of its utility, clearly at the time there wasn't much else in terms of an analysis. We were also working alongside other sources of information, and the ONS had started to publish mortality data demonstrating the differential impact of COVID on black and ethnic minority groups. So this helped build our understanding, but with the limitations, we had to interpret it alongside other sources of information.
Or did it build an accurate understanding, or did it build just a general understanding?
I think it contributed to the understanding. It wasn't the whole understanding because of the limitations of the use of this, but it was useful in informing the work of the BAME advisory group.
I want to ask you about hospital capacity and modelling now. It's correct that Public Health Wales didn't have any role in providing advice or guidance on the capability of different sectors of healthcare systems to scale up or scale down to areas of need. Is that right?
That's correct.
But Public Health Wales did have a role in modelling reasonable worst-case scenarios, which was then used to inform how that capacity should be scaled up and scaled down. Is that correct?
That is correct.
And if we could please have on the screen INQ 000469675, it's page 17, paragraph 49. And this is the Public Health Wales statement. And we're saying there that the model from NHSE was refined because I think it's correct that Public Health Wales didn't have the capacity or the capabilities to come up with a reasonable worst-case scenario. So the one that had been created by England was adopted for Wales. Is that a broad summary of it?
It was used to model potential impact in Wales at the very early stages.
And then there was a disagreement between Public Health Wales and the Welsh Government about whether it should use 25% or 40% of the reasonable worst-case scenario. And as it's 4 lines up from the bottom, Public Health Wales is unsure as to why the Welsh Government provided estimates of 40% of the reasonable worst case. The effect of using different percentages to reduce the numbers. Just want to unpack that a little bit. 25 or 40% of the reasonable worst case scenario, what does that actually mean?
So the reasonable worst case scenario is a prediction about the worst scenario that health services could face in terms of the COVID as it was emerging at the time through modelling trajectories of cases.
Her ladyship's heard a lot about this in Module 2 in particular, so yes.
Okay. So the reason for choosing something less than that was to allow health service planners to also plan for other contexts where perhaps it was 40% of the worst case scenario or 25% of the worst case scenario, so that there was an understanding that if the worst case scenario didn't emerge as to be the case, then this is what 40% or 25% might look like. And as we said in my statement, the first wave actually produced 7% of the revised worst-case scenario.
Yes, but I'm struggling to understand what 40% is. Is it 40% of the numbers that are in the reasonable worst-case scenario? I mean, what actually was it? Because it sounds like a multiplier, but it doesn't seem that straightforward.
It is a multiplier, so it's 40% of the numbers you would expect from the reasonable worst-case scenario.
Was it based on a 40% compliance with control measures in Wales?
No, it's based on 40% of the numbers predicted through the reasonable worst-case scenario, and therefore planning what hospital admissions might arise from that, and therefore the resources required to meet with that demand.
Okay. Why was the Welsh Government providing estimates rather than Public Health Wales?
Well, Welsh Government were using an interpretation of reasonable worst-case scenario to help with their planning. And Public Health Wales, in the early stages, recognised that it didn't have a primary role in modelling. It didn't have the capability to undertake sophisticated modelling, and therefore it looked to the modelling that was undertaken in England to extrapolate to Wales to give an early indication of the capacity demands of the system.
So whose primary responsibility was it to model that capacity? Public Health Wales or the Welsh Government?
It wasn't Public Health Wales.
It was or wasn't, sorry?
It wasn't Public Health Wales.
I want to move on now then to infection prevention and control. So there's a team within Public Health Wales called the Healthcare Associated Infection Antimicrobial Resistance and Prescribing Programme. I think the acronym's HARP.
That's correct.
And it was HARP who engaged with the UK IPC cell, and the head of HARP and the assistant medical director and the consultant nurse within HARP became members of the COVID the UK IPC cell. Is that right?
That's correct.
And was it right that effectively HARP didn't create IPC guidance itself, but it applied the UK IPC cell guidance?
That's correct.
Were there any ever differences of opinion about what the form of the guidance should be between Public Health Wales and the UK IPC cell?
There wasn't. We were completely aligned.
Did Public Health Wales have any capacity or capabilities to be able to independently, so distinct from anybody within the IPC cell, assess the routes of transmission, the benefits of masks, any of those elements?
No, there was no need to because of the construct of the UK IPC cell and how it looked to emerging evidence and considered it in issuing updates on the guidance.
Okay. Did Public Health Wales engage with any groups in Wales, professional bodies, representative groups, patient groups, about IPC guidance and what it should say and any of their views on its impact?
So we established a network of healthcare epidemiologists just before the pandemic. And these epidemiologists are in each of the 6 health boards where there are hospital settings. And they work very directly with the infection prevention and control teams locally. And through that network, we were able to stay in touch with the experts at a local level. We also liaised with the Welsh Government Nosocomial Transmission Group that was co-chaired by the Deputy Chief Medical Officer and the Chief Nursing Officer.
I want to ask about the relationship between PPE and IPC guidance. Did at any point in time the availability of PPE drive the way that the IPC guidance was constructed, as opposed to whether it was able to be applied in due course due to supply issues?
I am led to believe that the UK IPC cell did not consider the shortage of PPE in their considerations as it was outside the scope.
So I think you're careful when you say you were led to, that you weren't enrolled at the time. This information has been given to you. Were you aware, or was Public Health Wales aware that there were differences within Public Health Wales itself about whether there should be a greater use of FFP3 masks compared to FRSMs during 2020?
I'm aware of the email from Brendan Healy, one of our consultant microbiologists, and you will have received that communication in an exhibit. And we clearly responded to the inquiry around the wider use of FFP3 masks. And clearly in the hierarchy of controls, the use of personal protective equipment is the last thing one would consider. So we would look at elimination, substitution, administrative and engineering solutions before looking at personal protective equipment.
Yes, but I'm just interested in discussions within PHW, because if you had that individual who was sending the emails, I believe he says this isn't the first time I've raised it, were there internal discussions within Public Health Wales about what they should be saying at the IPC cell about whether there should be greater use of FFP3s? And if so, what was the outcome of those discussions?
So the response to the email was guided by the UK IPC cell guidance, that actually we need to consider this as a whole, that if there are outbreaks or concerns about local transmission, there needs to be a root cause analysis to identify whether additional precautions need to be taken over and above the use of PPE. And that advice was given and in response to the email.
Yes.
Can I just go back to the hierarchy of controls, Professor? I have some problems with it. And can I explain one of those problems, which you've just touched on? If your first port of call is elimination in the hierarchy of controls, why isn't personal protective equipment part of your strategy for elimination? Surely if more people are protecting themselves from catching the virus, then that's going to help with elimination. So why are they separated and put into a hierarchy? Why are they not a package of measures as opposed to hierarchical structure?
I think there is a rationale behind the hierarchy of controls that actually in a healthcare setting, elimination might not be an option because you can't eliminate the threat from a hospital setting because that is the very place that people will seek treatment if they have COVID. So I think the elimination agenda may not be applicable in some settings as easily as in other settings.
Not sure you've addressed the question. My question is, why is the hierarchy of controls a hierarchy as opposed to, right, we've got this virus, it's possibly spreading, and here are a package of measures that we can put in place to try and make sure it doesn't spread too far?
I think you're right in describing as a package of measures. And I think the hierarchy connotes some of the earlier steps you might take in order to control the transmission of infection. And in some settings, elimination is an absolute option. In others, it is more challenging.
But when you're talking about, for example, an emergency department, a waiting area, something along those lines, where you can't eliminate it,
Exactly.
then I think when you're talking about a package of measures, you need to look along those lines as you deal with it effectively as a collective piece.
Indeed.
I just want to look at one particular document. It's 398244. This is the IPC cell meeting of the 22nd of December 2020, which we've seen on a number of occasions in the inquiry. And it's 4 lines up from the bottom. ED, I think that there is Ellery Davis, and she was head of HARP, is that correct?
That's correct.
And she says that there'll be pressure from organisations and bodies for more precautionary measures. The confidence of staff in high-intensity units is being lost. If there's a high-risk pathway, we should take precautionary measures. So at that point in time, Public Health Wales is saying more should be done. Is that right?
So I think this is recognising that more should be done in the face of any high risk. And in this context, it could include aerosol generating procedures.
Right. But nothing was done as a result of this. I think the guidance stayed the same. Is that correct? After there have been discussions on the 23rd as well?
This was a discussion at the UK IPC cell at one of their meetings and will have informed the decisions of the group.
Fine. So Public Health Wales said, well, that's been the consensus of the IPC cell, and therefore we're going to abide by that consensus.
So the decisions of the UK IPC cell were clearly not individual decisions from individual members, but it was a collective consensus based on the scientific evidence available at the time and best practice where this was not available. And this discussion will have been taken into account in coming to the various iterations of the UK IPC cell guidance.
Right, so effectively Public Health Wales did abide by the consensus view that was taken at the cell, is that right?
It did.
So even though at this point in time it had been recognised that the confidence of staff in high intensity units is being lost, if the consensus was then followed, what steps did Public Health Wales take to ensure that the confidence of staff was maintained?
So it reiterated the elements in the UK IPC cell that talked about local risk assessment, and it talked about identifying root causes in order to put in interventions that would better control transmission.
That sounds a little bit like there's being a repetition of what the guidance already says. Surely this required a bit more in order to retain the confidence of healthcare workers in Wales. Was that done?
So in terms of, doing more, there was a report published in September 2020 identifying lessons learned with lots of elements that describe the measures that we should take in securing strengthening the ability to avoid nosocomial transmissions.
But did anybody from Public Health Wales talk to any representative groups of any healthcare workers and say, look, we recognise confidence is being lost. This is the reason why we're taking these decisions. Please have confidence, and actually explain it to them, rather than simply pointing people back to the guidance that they were already losing confidence in?
I'm not aware of any direct conversations with healthcare workers. Our work on the nosocomial transmission group was to coordinate this across Wales through that group.
Ventilation, then, Public Health Wales didn't have any role in advising about ventilation or portable air cleaning devices, is that right?
That's correct.
Despite the fact that ventilation was an important part of IPC guidance?
That's correct.
Why did it not have any such a role?
It's not for me to speculate why that is, but there are other parts of NHS Wales that have that role.
Well, do you think it's a useful role for Public Health Wales to have in the event of a future pandemic?
It might be a consideration, but with any role, we would need to ensure that we have the right capability and capacity to fulfil that role competently.
Before I look at nosocomial infections, I just briefly want to touch upon visiting. Did Public Health Wales provide any IPC assessment to show the relative benefit of imposing visiting restrictions for pregnant women and partners at hospital?
So the Chief Nursing Officer in Welsh Government established a hospital visiting group that we were part of and contributed to the discussions of. We didn't issue any guidance directly on this issue.
Did you provide any specific advice about visiting restrictions?
I don't have that information.
Did that visiting group seek the views of patients, families, about changing rules, the application of visiting guidance or not?
I don't know.
Do you think that the role of families was actually taken into account within that visiting group, or do you not know that either?
I don't know, but I assume it will have.
In terms of nosocomial infections then, I think it's right that there was a report in 13th of April 2022 which identified that there were more than 10,000 probable or definite hospital-acquired cases in Wales over the pandemic period. Is that right?
That's correct.
And probable there is defined as 8 to 14 days after admission to hospitals when they test positive, and definite is 15 days or more. Is that right?
That's correct.
If we can please have on screen INQ 000276011, page 4. And ACM there we see referred to, that's all-cause mortality, is that correct?
That's correct.
And if we just zoom in, please, on table 2, if possible. So we can see there a table which sets out the various different categories across the Wales, and this is across the entirety of Wales. So one I want to focus on is probable hospital onset and definite hospital onset in wave 2. Looks like probable and definite hospital onset is over 50% of cases of COVID in the population during wave 2. Am I reading that correctly?
That is correct.
And when we're talking about wave 2, I think we're talking, is that September 2020 through to July 2021?
I think it's September to May.
September to May, yes.
July to May.
July to May. So what lessons have been learned from wave 1 about how to prevent nosocomial infections between wave 1 and wave 2?
So the document we published was in September 2020, and that set out a range of lessons learned, and this was shared with the directors of nursing in Wales. It was also shared with the NHS Leadership Board through the Chief Nursing Officer, and it was used on an ongoing basis through our network and ongoing communications with the infection prevention and control teams at the health boards.
Okay, but what specifically was learned?
The lessons identified are wide-ranging, and they include elements around testing and case definition, disease presentation, IPC and PPE use, patient placement, staff movement, social distancing.
Do you think that those lessons had been learned, or even if they were learned, whether they were necessarily entirely effective, if more than 50% of cases in Wales were probable or definite hospital acquired in wave 2?
I don't have the information to confirm or otherwise whether the lessons were learned, but the lessons were identified. And in commenting on the mortality rate in different waves, I think that also has a bearing on the severity of the variant concerned, because during most of that period in the second wave, we were dealing with the alpha variant at the time, and that may have a different characteristic in terms of clinical impact when compared with the other variants, such as Omicron, that was predominantly during wave 4.
Yes, but you're also then looking at preventing infections in hospital, because even if your mortality isn't, really death doesn't occur, you still have serious illness, issues such as long COVID that arise. So standing back and looking at what happened in wave 2 and subsequently, could more have been done to prevent nosocomial infections in Wales?
So we can see that the numbers of probable and definite hospital onsets as a proportion actually reduced throughout the pandemic. And when you look at that table that you've highlighted, the percentages have continued to reduce from a total of 70% in wave 1 to 24% in wave 4.
I'm not sure I understand the statistics, but I think I'll have to work that out myself in due course. Can I please just ask you briefly about long COVID? Did Public Health Wales have that document come down now? Thank you. Did Public Health Wales have any role in identifying long COVID within 2020, or putting in place any treatment measures that should arise for long COVID?
Public Health Wales doesn't have any services that would address symptoms of long COVID, and it didn't have a role in monitoring it.
Did it have a role in identifying long COVID as a concept?
No.
So Public Health Wales doesn't have any role in identifying long-term impacts of a pathogen?
It hasn't so
pandemic?
far, no.
Do you think that would be a beneficial addition to its role?
It could be.
And then finally, the last point I want to touch upon is shielding. So Public Health Wales didn't have any involvement in the development of guidance in Wales around shielding. That was led by the Welsh Government and coordinated through clinical teams across the health boards. Did Public Health Wales provide any advice about any aspect of the support, the health that should be offered to those people who were shielding or their families?
We didn't, and nor were we asked.
Just very finally, are there any recommendations that you would wish the Chair to consider?
So I have 3 suggestions. One is for the 4 nations of the UK to work closely together in the pandemic, and we've seen some of the benefits of that in coordinating the UK IPC cell guidance, which applied equally across the 4 nations. And early involvement of the devolved administrations, particularly in the development of guidance, would be very beneficial. The second is with respect to what we do in preparedness now for the next pandemic, to clarify very clearly roles and responsibilities of different agencies, to learn the lessons of exercises that we undertake, but also to undertake exercises at a national, regional, and local level so that we get through the operational, tactical, and strategic aspects. And the final thing is around research, and to focus on undertaking and coordinating priority research studies at the beginning and putting in processes to enable research to be undertaken efficiently, effectively, and that are well-resourced.
Thank you, Professor Corp. Those are my questions.
Can I ask you to go back to your second possible recommendation, Professor? You said to clarify the roles and responsibilities of various organisations. What areas were there where you felt there wasn't sufficient clarity of the roles and responsibilities?
I think this was manifest during Module 2B, and in terms of the early experience we had around contact tracing and contact centres, that for that to fall to one organisation without the ability to surge was quite challenging. So having clarity around our surge capacity, the workforce that we have in readiness to surge, and what digital solutions there might be to help us would be really helpful during this planning phase.
Thank you. Right, those are all the questions Mr. Scott has for you. Mr. Wagner has some questions. He's over that way.
Thank you.
Good morning. I ask questions on behalf of 13 pregnancy, baby and maternity charities. I only have one area to ask you about, and it relates to visiting guidance. You said in your answers earlier, the Chief Nursing Officer in the Welsh Government established a hospital visiting group that you, Public Health Wales, were a part of and contributed to the discussions of. Do you recall during those discussions whether any consideration was given to the health benefits of pregnant people having their partners available? Just for example, having a support partner able to assist them post-birth rather than requiring a nurse for assistance?
I don't have any specific recollection, partly because I wasn't in those discussions, nor have I been given information to suggest that was a specific discussion by the group.
Thank you. That's my question.
Thank you, Mr. Wagner. Ms. Foobster, she's behind the pillar.
Thank you.
Good morning, Professor Kaur. I represent John's campaign, Care Rights UK and Patients Association. And I've got some questions about the impact of public health messaging on access to healthcare. At paragraph 104 of your witness statement, you say that you understood that some patient groups had concerns about people with chronic health conditions not accessing or attending key appointments. What did you and/or Public Health Wales do about those concerns?
Thank you. The coordination of public health communications was something we worked together as a system so that no single organisation would be seen as leading. And we always worked very closely with Welsh Government, who clearly oversaw the policy context. So Public Health Wales communications team would advise on statements and on the communications strategy.
Just specifically on my question, though, in relation to your understanding that there were concerns about people with chronic health conditions not accessing or attending key appointments, did you do anything in response to learning about that?
We didn't do anything specifically, but we did share that information with the relevant groups.
And why did you not do anything about that?
Because we are part of a system and there are implications of communicating to the public about access to services that were beyond our direct control. So we would have to work in collaboration with other parts of NHS Wales, for example, health boards who provide those direct services. Because if we're signposting people to access those services and the services are not prepared to take them, then we wouldn't be communicating the right messages. And
who did you tell about these concerns about people with chronic health conditions not attending appointments? Who were the specific people that you shared that with?
So I do not recall, and I do not have the information to know where that specific information was shared with, but we can get that information for you.
Thank you. At paragraph 103 of your witness statement, you say there was no systematic assessment of what the impact of the stay-at-home messaging would be on planned and emergency care. Would such an assessment have been helpful?
So we did undertake a health impact assessment to look at the impact of the social distancing and stay-at-home policy, and that report was published and shared widely within Wales, and that demonstrated some of the downsides of the policy and highlighted some of the concerns around health-seeking behaviours.
But just, you do refer to the health impact assessment at paragraph 103, but your first couple of sentences in that paragraph explain that there wasn't a systematic assessment. And so presumably you're drawing a distinction between the health impact assessment and a systematic assessment. And so what would the systematic assessment have provided that what was done wasn't able to?
So I think I would see a systematic assessment as something that was routine, that was undertaken on a continuous basis. The health impact assessment was a one-off assessment in light of the change in policy.
And at this section of your witness statement, you also talk about there being limited information about what the impact ultimately was of the stay-at-home messaging. There's those two health impact assessments that you refer to. Why weren't steps taken to collect or monitor that information, including from patient groups?
I cannot answer why that wasn't taken, but at the time, I think the policy decision and its impact might have been another organisation's responsibility because it didn't directly relate to health protection. And which organisation would you say would have been responsible if it wasn't Public Health Wales? I cannot specifically answer that at this time, but I think this is something we might need to consider going forward.
Thank you. Thank you, my lady.
Thank you very much. Ms. Polishek, I think she's... Oh, that way.
Good morning. I ask questions on behalf of clinically vulnerable families, and we just have one set of questions today in respect of the public health measures that were taken to protect those who were particularly clinically vulnerable to COVID-19. The Chief Medical Officer, Frank Atherton, gave evidence to this inquiry that he recalled that close consideration was given to providing clinically extremely vulnerable patients with surgical masks. Do you recall, or are you aware, that there were discussions about providing either clinically vulnerable or clinically extremely vulnerable patients with masks? And if so, which type of mask was considered appropriate for their risks of catching COVID?
I'm not aware of those discussions.
Thank you. In which case, Madam, that is my question.
Thank you very much. Mr. Thomas, he's behind you. Professor, if you could make sure, please, that even if you look at Mr. Thomas while he's asking the question, your answer goes to the microphone. Thank you.
Good morning, Professor Crowell. I'm representing FEMHO, that's the Federation of Ethnic Minority Healthcare Organisations. And FEMHO is particularly interested in how data tools and methods can be refined to better understand and address the health disparities within these communities. At paragraph 151 of your witness statement, you referenced the ONOMAP tool. Mr. Scott referred to this earlier on today, which was a 2021 study to analyse ethnic disparities through name-based classifications. Question. Given the recognised limitations in using names alone to infer ethnicity, how effective do you believe the ONOMAP tool was in accurately identifying ethnic health disparities during the pandemic?
Thank you. Clearly, the strengths and limitations of the use of ONOMAP are detailed in the published paper, and I wouldn't want to repeat those, but we did recognise there were limitations in the findings as a result of that. And therefore, we were keen to look at other evidence sources to develop our understanding about the differential impact on BAME communities. We knew at a very early stage of the differential mortality outcomes reported through the ONS, which collects data through death registrations. And so this evidence that we generated proactively contributed to our understanding and contributed to understanding, particularly in Wales. And some of the findings were interesting around younger people, greater admission to intensive care units, and also mortality rates. But it was part of our wider understanding about the differential impact.
Okay. I think you've touched upon my second question, so I'll move on to my next question. Following the findings derived from the ONOMAP tool in identifying ethnic disparities, did Public Health Wales explore other methods or other tools to complement these findings and further close gaps in understanding ethnic disparities?
So our work on ethnic disparities relies on information about ethnicity, both in terms of the numerator, i.e. those people who were confirmed to be COVID positive, and the denominator, i.e. those people in Wales and their ethnic background. Without the denominator, it is very difficult to make assertions around significant differences between different population groups. And the owner map allowed us to understand the numerator, but not necessarily the denominator. I know it's a very technical response, but in the absence of good denominator data, then the evidence generated through these other studies may have limitations, and we've identified that with the use of owner map.
Sorry, I don't think you quite answered my question. Let me repeat it. My question was, you recognise that there were limitations with this tool. Simple question. Bearing in mind you recognise that, did you use additional tools to assist in your understanding?
So I repeat my response, which is any investigation on disparities for ethnic minority groups relies on good quality data. And we didn't have access to data around ethnicity, both in terms of people with COVID and in terms of people who didn't have COVID, which therefore limited our ability to undertake any more robust investigations around differential impact. And in our assessment, the use of the owner map tool, which we had applied to other areas with some success, was a good a tool for us to explore how it could contribute to the science.
So is the simple answer to my question, no, we didn't use additional tools?
That's correct.
Thank you. If, as you've just accepted, no additional tools or methods were employed to supplement the owner map findings, would you agree that this represents a critical gap in the data?
That's correct. And this is why the First Minister's BAME group made several recommendations in its report from September 2021, and one of this was about strengthening the data around ethnicity in Wales.
Let me come on to my third and final area. And I want to be forward-facing to assist the inquiry. In your view, what should future public health strategies implement to address these data limitations to ensure a more accurate and inclusive representation of ethnic disparities in health outcomes?
So a fundamental building block for this going forward is to improve our data collection around ethnicity status for all people in Wales. And I understand that work is ongoing.
And just following on from that, what role do you think cultural competency should play in any future public health data collection efforts?
I believe very strongly in cultural competency for all, in all that we do, that without an understanding about differences between ethnic groups, it will challenge the effectiveness of the work that we undertake. So I think it has an important bearing for all parts of the process around developing cultural competency.
Professor, those are all my questions. Thank you very much. Thank you,
Thank you,
lady.
Mr. Thomas. Ms. Woodward, I think you probably can see her directly.
Thank you. Good morning. I ask questions on behalf of COVID-19 Bereaved Families for Justice Cymru. And I'm going to ask you some questions about what was covered at the very start of your evidence, and that's in regards to data collection in Wales. And you've already been asked some questions about the COVID-19 mortality surveillance e-form. And as I understand it, your evidence was that some elements of that form were not as well completed as they might have been, and that led to lots of missing data. As well as forms being completed with missing data, and despite the assurances at paragraph 110 of your witness statement that the timeliness of reporting to that e-system was good, would you also accept that, as set out in the review of the reporting of COVID-19 deaths in Wales, Professor, that paper is at tab 19 of your bundle if you want to turn there, and the reference is INQ 000395663. So would you accept that, as set out in that report, that there were also difficulties with health boards failing to use the new centralised system, which led to delays by health boards in the reporting of deaths, and that there were also difficulties with ambiguity in the definition of what constituted a death to be reported, and that this led to the underreporting of deaths in at least 2 health boards in Wales?
That's correct.
So given those delays and the underreporting, would you agree that the system therefore wasn't even working well to find out how many people had died of COVID, let alone where that infection had come from?
So the issues identified in the report that you referenced talks about the identification on the 23rd of April, for example, of 84 deaths in one of the health boards. And the e-form was implemented following an instruction from Welsh Government on the 23rd of April to address this very issue. We had mechanisms to ensure timely reporting from clinicians on an ongoing basis. And as I said earlier, initially weekly meetings chaired by the chief statistician and the director of public health services at the time.
The report, though, also sets out difficulties with using the e-form at the start of its implementation as well. So there were continuing difficulties, weren't there?
Yes.
Sticking with data, in your evidence earlier, as I understand it, you agreed that nosocomial infection data was something that was well within the Public Health Wales remit. And you also recognised that testing was, of course, a limitation of data collection. In written evidence given for Module 2B, Andrew Nelson, who's the Chief Information Officer at Cwm Taf Morgannwg University Health Board, and you've already been taken to his statement, Mr. Nelson is critical of the use of data in Wave 1, as no consideration was given to differentiating community and hospital-acquired infection. And he infers that a lack of reporting and awareness may have resulted in people not thinking about healthcare-acquired infections as being as much of an issue as it became. My question is this: do you agree that there were specific difficulties in differentiating between hospital and community-acquired infection in the data in Wales?
We relied on definitions of this, and I think ultimately we had a 4 nations agreement of what would be counted as a community onset case and what would be a probable or a definite hospital onset case. Once we agreed those definitions, we were able to apply them to the data analysis that we had. So I don't think technically there was an inability to do that because we had access to the data sets to allow us to link the data. But it may be a question more about agreeing the technical definitions of what would constitute a hospital onset case.
And would you accept that that may therefore have posed a problem at the local health board level, as identified by Mr. Nelson in his statement?
It is possible. It is possible that the lack of accepted definitions may have affected the early work on this.
Apart from the weekly meetings that you described earlier in your evidence, were there any other measures taken by Public Health Wales to address any of these difficulties in relation to data collection and reporting and the completion of the e-form monitoring?
Nothing in addition, and in those meetings we would provide the latest analysis so that people were cited on the gaps. And clearly with health board representation, we would look to them to implement any improvements locally.
And Professor, would you therefore agree that there was in fact no comprehensive form of monitoring put in place to ensure that health boards at the local level had rectified any reporting areas other than simply attending a weekly meeting?
Well, attending a weekly meeting clearly had responsibilities for the person attending to take back any improvements that were discussed, and we relied on that mechanism. It wasn't for Public Health Wales to hold people to account. It is not our role to hold health boards accountable for the information they provide, but we can help by providing information that would hopefully lead to improvement. but recognising that, the e-form was one of many things that people had to complete.
You say that it's not Public Health Wales' role to hold health boards to account, but would you agree that it is part of Public Health Wales to ensure that data collection and reporting is happening as accurately as possible so that you know what's happening on the ground in pandemics such as...
That's correct, which is why we engage very actively with those routine meetings.
Thank you, Professor. Thank you, my lady. Those are my questions.
Thank you. Those are all the questions that we have for you, Professor. Thank you very much for your help in providing your statement and for coming to the inquiry to give evidence today.
Thank you, my lady.
We shall break now. I shall return at 11:30. Scott.
Lady, may we please call Aidan Dawson?
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
full truth.
the whole truth, and nothing but the truth.
Let's take a seat. Thank you.
Mr. Dawson, can we have your full name, please?
Aidan James Dawson.
And you are currently Chief Executive of the Public Health Agency, is that correct?
That is correct.
And you've had that role since July 2021, is that right?
I have.
And prior to that, you worked within the Belfast Trust, is that correct?
Sorry. Yes, that is correct.
And is it right that you personally don't have a clinical background?
Yes.
Healthcare management is your primary background, is that right?
Yes, that is correct.
And so you haven't held a role in prior to July 2021 in PHA, so it wasn't that you've gone to PHA and then to Trust and then back to the PHA?
No, I have never worked in public health prior to taking up the role of Chief Executive in 21.
So in terms of the statement that's been provided on behalf of PHA, that's been done in conjunction with people who were within PHA at the time, is that right?
Yes.
Where's the self-reflection of the PHA, the critical analysis of what went well and what went wrong in terms of the role that PHA played during the pandemic?
I think some of that comes from the Hussey review, which we have built upon, and since I've taken up post and we've moved out of the pandemic, we have gone into a significant review of the agency, its structure, its operational capability, and how it prepares and works as an organisation to support the people of Northern Ireland.
It doesn't appear to be set out in terms of the role that the PHA played during the pandemic. It doesn't appear to be set out in the statement, any of that critical analysis.
Sorry.
Is that a fair assessment or not?
I think that's perhaps a reasonable assessment, yes, but I do think it also builds on what we've learned through the pandemic.
Why isn't there that critical assessment in a statement from the PHA to the UK COVID-19 inquiry?
I suppose we built our review around what public health agencies should be. I do believe we've taken into consideration as we've moved through it, learning from our reflection of what we went through in the COVID inquiry as an organisation. But we're also hoping that we will, and it's an iterative process as well, and obviously we will learn as we go through the inquiry as to what lessons we should take out of that.
So has there been any internal proactive assessment of the PHA's performance during the pandemic, or is it waiting for reviews or external bodies to assess the performance of PHA?
I think the review is an assessment of what we went through to some extent, probably not as critical as you have suggested, so I would concede that.
I want to move to staffing and capacity of the PHA. So at the start of the pandemic, was there sufficient staffing and capacity within the PHA to perform the roles and functions it would envisage that it would have during the pandemic?
No, there wasn't. I think critically we did not have enough in terms of professional public health qualified individuals, and that issue is being addressed through our review. We have also put in place 2 additional training numbers for public health consultants above what NIMDA actually provide us with.
So NIMDA, if you could just define that, please.
Northern Ireland Medical and Dental Training Agency. So they are the primary trainers of doctors and dentists across Northern Ireland.
Okay, so if you didn't have enough professional public health qualified individuals, how did that impact upon the PHA's response to the pandemic?
It hampered it, although we would identify that we had a number of people who had retired and returned as well, who had significant experience come back many years.
Right, and is it also correct that during the pandemic, staff were seconded to work directly to the Department of Health, or redeployed or redirected to work in new areas? Is that right?
That is correct.
And is it also right that a number of the staff who were seconded to the Department of Health were actually your senior staffers?
There were some senior staff as well, yes.
So, again, after those individuals have been seconded to the Department of Health, was there sufficient capacity and capability within PHA to perform the roles that it had at that point in time in relation to the pandemic?
I think at that point in time we worked so closely with the Department of Health, there was a balance between where those individuals sat and where they could best provide service during the pandemic. And I think that we probably didn't have enough, but we did the best with what we could at the time.
So can you provide any specific examples of where that insufficiency of capacity and capability hampered the service that PHA could provide?
I think we had, and it's borne out in the Hussey review as well, that we didn't have modelling capability as a public health agency going forward, or at that time, and I think that was one of the areas that we were hampered. We did work very closely with the department and with Department of Health, I should say, and we established a modelling group that sort of worked between the department and ourselves. But I think one of the things that we have learned coming out of the pandemic is the necessity to have our own modelling capability going forward.
So you didn't quite have the modelling capability that you required.
Mm-hmm.
Did you have the ability to conduct surveillance of data and cases that you needed as PHA?
I think we lacked in terms of we had the capability for sort of day-to-day work that we would have had, but for something on the scale of the pandemic, I don't think we had that capability when we started the pandemic, no.
Did it improve throughout the course of the pandemic, or did it get worse?
It did. I believe it did.
In what way did it improve?
I think our information became better, and we worked very closely with the trusts, the Department of Health, and Queen's University as well, I think, in developing our information flows, where we would draft information in from to give us a better understanding of how the disease progressed.
Two very closely related questions. One, what was the reason why you didn't have that capability? And two, how do you prevent that happening in the event of a future pandemic?
Well, I wasn't there pre-pandemic, so it's hard to say that. I don't think that we...
Presumably it's a question that you've asked in preparation.
Yeah, yes. I think it's one of the... We as a... In Northern Ireland, we did not embrace the mixture of multidisciplinary approach in terms of developing public health consultants, which the rest of the UK has adopted. We have since addressed that, and we will do that going forward. But I think that's one of the key reasons why we didn't have the people coming through.
And is that a PHA failure to identify, or is that the department or anybody else?
I think probably both. We're a very small system in Northern Ireland. We work very closely with the likes of NIMDA and the Department of Health, and I think that there has been, probably fair to say, we haven't invested in sort of public health consultants and capability, but you could also say that of many other medical specialties across Northern Ireland at this point in time as well.
I want to look now at data and surveillance in terms of what PHA did with that information. So Joanne McLean gave evidence to Module 2C. Could you just please tell us in terms of what Ms McLean's role was within the PHA?
Well, currently she is the DPH for North
Director of
Public Health, yes. And that's why she was given evidence at that time.
Okay. And she says that in her evidence, this is at page 28 of her transcript, it was a really important part of responding to infectious diseases is knowing how many infections are on the community and any changes to that infection, and the technical term for that is surveillance, and that was a core bit of our function. Presume you agree with that completely?
Yes.
Did you actually have the level of surveillance in terms of the primary care data that you needed during the pandemic?
I don't think we had that sort of level of primary care data that we would require.
And did you have the requisite level of critical care data that you require?
Not at the beginning of the pandemic, no.
Was there any type of data that you did have that the level that you required?
I think we, as I said, we would have had normal sort of surveillance data around flu and around RSV and sort of conditions like that, and things which sort of would have come up on a seasonal, sort of normal seasonal process throughout the year.
But when you went into the pandemic, so let's say this is January, obviously because Public Health Agency had been aware of the Wuhan virus in January 2020, that's fair? Yes. So did you look then at the data and the information that you had available to you and think, is that sufficient, or do we need to get access to more?
I don't know exactly what they would have considered at that point in time, but I do know as we sort of moved in through March and April that there was concern that we didn't have the access to information that we may have needed.
Okay, so you said March and April there. So
yeah.
Lockdown was 23rd of March 2020. So it was still in April 2020 that you were concerned that you didn't have the information you needed?
Well, I think at that point people were discussing what sort of information we would need and how you would develop those information flows out of such areas as critical care.
Okay, and so what did you identify you required, and how did you develop those flows?
We had a small team sort of identified, sort of led by sort of Declan Bradley, who's one of our public health consultants working with others, to identify the number of people coming into critical care that might have COVID and the pressures that was exerting.
Okay. And so when are you satisfied that you had accurate information about the people coming into critical care that might have COVID and the pressures that was exerting?
I think around about sort of April, May. But I think that sort of the confidence in the data grew over a period of time.
Is that not the end of wave one, that the confidence in the data actually
I think
arrived?
Yeah.
Any other areas in terms of critical care?
Not that I'm aware of.
And so are you satisfied that at the end of, let's call it the end of May, that there was sufficient information that PHA had about critical care? Or was there more that you required?
I think at that stage they were pretty sure that they had sort of the information they require, but I'm not wholly sure of the answer to that, really.
Okay, because can I show you, please? It's PHA statement. It's INQ 000 485 720. It's at page 41, paragraph 116. It's a tab 1 of your bundle, or it's going to be up on the screen. So this is the genesis of these questions. The data was most challenging with primary care and critical care. And it talks about that there was access to the influenza. Is that what you're suggesting? The surveillance of flu, RSV was available?
Yeah.
And information was initially considered to be potentially relevant and useful, but upon discussion with HSCB, just in terms of the acronyms, HSCB is effectively the commissioning body. It no longer exists, but it was between the trusts and the Department of Health at the time. Is that right?
That's correct.
And so it was established that there were no permissions for the primary care data owners to use this source for COVID-19 monitoring, and it was not subsequently used. That sounds like data access was preventing PHA getting access to information it needed during a pandemic. Is that right?
That is correct.
What steps were done to break that data access block?
Discussions between sort of the primary care, Health and Social Care Board would have primary responsibility for the management of primary care contracts. So there was a significant piece of work done with the Department of Health and Health and Social Care Board around data access agreements over that period of time. But I think that probably took too long.
Was that because it was August 2023 that it came in?
Yeah.
So it's 2.5 years.
Yes.
Could things not have been moved a little bit quicker to get access to the information PHA needed in primary care about tracking cases of COVID-19 in Northern Ireland across the lifetime of the pandemic?
I think in hindsight, yes. And I think there's...
Well, surely it's not just hindsight, though.
Yeah.
So was there any consideration taken to passing legislation, for example, to get access to the information that you needed?
Not that I'm aware of.
Who were the primary care data owners?
So my understanding is the primary care data owners are the GPs themselves.
That's what I assumed, but I just wanted to check.
Because is it right that there's not a centralised system like you might find in other countries, the United Kingdom? Is it that each one has their own system? Is that broadly correct at the time?
Yes, I think there's actually 3 different systems in use. I think they're now moving towards one type of system, and each GP is obviously their own independent contractor for their practice.
Okay. And then just moving slightly further down that paragraph, individual level critical care data. What does individual level critical care data mean as opposed to systemic data, which I presume is the opposite?
I suppose individual critical care data is specific to the individual patient.
Right. So that was initially reported manually to the PHA and then was discontinued. Why was that?
I think because my understanding is that then they had sort of flows established that came straight in from the information systems.
Right. And so as of August 2023, so at the same time, governance arrangements and data transfers have now been established from critical care units in Northern Ireland to the PHA for the purpose of monitoring epidemiology of severe COVID-19 and respiratory infections. Again, so why did that take 2.5 years to get those governance arrangements and data transfers in?
I think that's what's been established in August 23, but my understanding is that we would have had flows directly from the the ICU and HDU facilities during the pandemic as well.
Okay. So what did the PHA lose out on by not having access to all that information from primary care and critical care?
I think we had a considerable lack of information in what was happening in the community in terms of tracking the disease. Whilst I think from sort of early on in the pandemic, we had good information about what was going through ICU, HDU and the hospitals. We continued to have a lack of information through primary care.
And that was all the way through till August 2023?
Not as good as you would have wanted it, yes.
What impact did that have upon the response of healthcare systems in Northern Ireland to the pandemic?
I think in terms of hospital level, it probably had very little. I think in community care, it continued to be a blind spot.
Why doesn't the same apply then to the information you're getting out of the critical care units? Or was information being sourced in a different way that meant that you had the information you needed?
I think because we were able to source information directly from critical care units, that allowed us a good picture of what was happening within the hospitals.
You said it was a good picture. Was it a sufficient picture that you needed in order to perform your role?
I think so.
How could it be improved in the future if it needs to be improved at all?
We are obviously now in Northern Ireland implementing a new system, Encompass, which relies on the EPIC hospital information system. That will connect up the laboratories, it will connect up the ICUs, etc., and give us a more complete digital picture and feeds of information into the Public Health Agency to give us a better facilitated view of what exactly is happening in the hospitals.
Does that system then going to include all the various categories of data that you would wish it to in the event of a future pandemic, such as age, gender, ethnic group, disability?
I understand it will contain all those, however, it will not reach into GP systems. So obviously where we've had a lack of information was in community care and in our in the community through our GP systems. EPIC is a hospital-wide system across the trusts and laboratories, etc. It is not in community care. They will continue to have their own systems, but I believe the data access agreements are now better and in place to better access through NIHAP. And please don't ask me what that stands for, I can't remember. But NIHAP is a system whereby we can access anonymised data through the GP systems going forward, I think.
So have the blind spots gone?
I wouldn't say it's completely gone, but I think the picture is improving.
What remains then?
I think we're probably still limited on what we can get out of it's not sort of complete access as you would want into it, because it's obviously coming out as anonymised data and feeds in, and our groups continue to work with our GP colleagues in SPPG, which is the replacement from Health and Social Care Board, to identify what feeds we should get. So I think it's an improving picture.
Okay. In terms of deaths and recordings of deaths, so your statement sets out that there's effectively during the pandemic there were two ways of recording deaths. Or two systems, maybe I'll put it that way. There was one through PHA, and then there was one through NISRA, Northern Ireland Statistics and Research Authority, if I got that right. I may get the
agency, I think.
Agency, thank you. But they were doing two different things.
Yes.
And actually, the PHA's role wasn't a role you had prior to the pandemic.
No, NISRA and the GRO, which is the General Registrar Office, I think, have the legislative responsibility for the recording of deaths in Northern Ireland. PHA, prior to the pandemic, had no role in the recording or reporting of deaths.
So why did the PHA get that role at the start of the pandemic?
I think expediency. The minister in Northern Ireland was frequently being asked about the level and impact and number of deaths that was happening. NISRA is quite a prolonged, there's a data lag, and therefore
So data lag, could you set out how long that is? Is that 5 days or is it longer? Or
I think it's longer than 5 days. Okay. So that data lag, when we were looking for sort of real-time data, was obviously causing concern. Whilst the PHA put in place a way of tracking deaths, it wasn't obviously as wholly accurate as NISRA, because it obviously goes through the death certificates and looks at part 1 and part 2. But we had data on deaths which allowed us to put forward sort of trends and make decisions.
Why wasn't it foreseen prior to the pandemic, and maybe you can't answer this question, by the PHA that in the event of a pandemic they might need to have an accurate and up-to-date system for reporting deaths from whatever pathogen was causing the pandemic?
I think prior to it, there was an assumption, because that legislative responsibility sits with NISRA, that would be provided through them, and we had never been asked, and I don't think it had ever been considered.
On reflection, do you think it should have been considered?
Yes.
Didn't it cause difficulties for the PHA, given its staffing and capability requirements we've discussed earlier on, at the start of a pandemic, to get a new function to track deaths when there wasn't a system in place for identifying those deaths? How was that likely to ever be an accurate and easy system to put in place?
I don't think it was easy to put in place. It was never going to be. It was something that we were asked to do at that time, and which our team worked quickly to put in place because we were asked to do so.
Did you push back and say, we just don't have the capability to do this?
No, I think people wanted to be helpful. I think people at the time thought that it was information that would be useful as well in tracking the progression of the disease. And as I understand it, there was no pushback at all.
Well, was it more beneficial to the response of healthcare systems for PHA to be helpful, or to make sure that there's an accurate system put in place which is sufficiently staffed and manned by those with the capability and capacity to do it?
I think at the time it was a very fast-moving environment, and I don't think whether or not people thought this is our responsibility. I think people did what they thought was the right thing to do at the time, and that's why they proceeded to do it. I don't think it was ever suggested that it was wholly accurate. I think what was suggested, it was a tool that allowed us to track progression and trends in deaths.
One of the features which we'll discuss is ethnic group data wasn't kept. Was disability data kept?
I think we had very poor data on both disability and ethnicity in Northern Ireland.
Why is that?
It's hard to say. I think certainly in terms of ethnicity, or in 2001 census, our people from a black and ethnic minority background were less than 1%. And I think even in 21, it's gone up to somewhere between 3 and 4%. And therefore, I don't think it ever got the focus that it probably required or deserved.
Well, just to put the numbers to that, so the 2021 census, and this is tab 19 of your bundle, INQ 000474456, that it was 96.55% is from the white ethnic group across Northern Ireland. So across the other 12 groups are identified in the census, that's 65,604 people.
Yeah. Out of a population of 1.9 million, I think.
Yes, but that's still 65,000 people whose impact wasn't tracked, is that right?
That's correct. And I would say, and I have said, I don't think that we had the focus that was appropriate on ethnicity or disability that is required.
Wasn't ethnicity important for a public health agency to perform its just non-pandemic public health functions?
I think the agency had a history of more focus working with people from a disability point of view or an ethnicity or migrant point of view on the ground in terms of working with community groups, as opposed to in the disease side of things. So I think in terms of health improvement, we had a greater focus on working with local communities, etc., as opposed to tracking disease and its impact.
Is it fair to say that PHA never chose to make it a focus to ensure that they kept that data?
Yes.
And has that changed since?
Yes, I think we're in the purpose of drafting a new corporate plan at this point in time, and we will refocus the organisation into how we address things in terms of ethnicity, in terms of disability, and that greater focused on people from a disadvantaged background across Northern Ireland.
So how did PHA assess the impact of the pandemic upon minority ethnic groups?
I don't think it did it at all. Or well.
At no point during the pandemic?
I think as time went on, we had a low uptake group in terms of vaccination, etc. But in terms of surveillance of hospitals and the impact upon people from a black and ethnic minority background, no.
I want to ask about staff infections and deaths. I believe it's right that there was effectively a spreadsheet, and this is the documents behind tab 3 of your bundle. It was a big spreadsheet that had been provided, I believe, from PHE originally,
Yeah.
and it kept a series of categories of data. And one of that was staff illnesses and staff deaths. And my reading of that is that that was never included in terms of the data was never inputted alongside those rows, yet other bits of data were put inside alongside other rows. Is that a fair reading of that document?
I think that is a fair reading of that document, yes.
Why wasn't it that there was any record kept of staff illnesses, staff deaths? Maybe staff death is easier to focus on than staff illnesses.
I think staff death was, when I discussed it with teams, was it would have been very difficult to differentiate as to whether those deaths through staff were due to them acquiring the disease in line with their work, or whether or not they had acquired it in the community.
But how can you tell that unless you actually keep the data and know where they were working at the time?
We just didn't have access to that data at that time. It is one of the things which we have now addressed going forward and that we will have, but it wasn't at that time.
Well, can I just understand the sequence? Was it that there was an assumption made that it wouldn't assist you because you didn't have access to the information about where people were working, whether it be home acquired or hospital acquired, and therefore you didn't seek the data? Or was it that you saw, I see you nodding, was it that way around?
I think it was the way around. We didn't see that the data would actually help us manage at that point in time.
On reflection, was that the right decision?
I don't know the answer to that. It's not something which I have reflected on sort of greatly, and I'd probably need to give it some more thought, but I'm quite content to do that.
Or has the PHA institutionally given it any thought, or no?
No. But if I may, if it is now one of the things which we are, I've said that, and I'm now reflecting that it is one of the things which we would collect and be able to do in a future pandemic. So obviously our information team have thought that that's one of the things, because my understanding is they are able to anonymise sort of healthcare workers, their vaccination status, and going forward, their cause of death.
So there is planning ongoing?
Yes.
How about keeping information or data about people who are suffering from long COVID? Is that information being kept?
Not that I'm aware of.
Does the Public Health Agency have any role in identifying those with long COVID, trying to provide information to the department or HSCB? I may have got the acronym wrong now.
The SPPG, no.
Thank you. About to inform them about commissioning that may need to be put in place?
I haven't been involved in any discussions for that. I can't for certainty say yes or no whether or not we have been involved in the provision of information around the commissioning of services for people with long COVID. But I am quite content to answer that question and come back to the inquiry if that's helpful.
Thank you. I want to look now at infection prevention and control. Again, it's right that there was a UK IPC cell, which the inquiry's heard a lot about, and then there was a smaller cell put in place in Northern Ireland. Is that right? And effectively, the Northern Ireland IPC cell didn't produce its own guidance. It followed and applied the UK cell.
That's
right?
correct.
Yes. Did the PHA have any or sufficient scientific knowledge capabilities to determine routes of transmission and create IPC guidance and response?
I think we had input into the national cell. I think the four nations worked very closely together on that, and therefore I don't think there was a necessity seen to replicate that, or whether or not we would have had that capability. I mean, Northern Ireland has always relied on Health NHS England and now UK HSA to provide to us sort of guidance in many areas.
Throughout the pandemic, there were obviously different periods of time when different areas would have different levels of COVID-19. Hospitalisations were different. Impact upon healthcare workers would often be different depending on the pressures that they were feeling at the time. Is that a fair summary?
That is correct.
So, to what extent did PHA see it as part of its role in terms of informing the IPC cell discussions to engage with healthcare workers, patient groups, anyone in Northern Ireland about what was being felt in Northern Ireland at the impact of those IPC guidance?
I'm not aware that we conducted an awful lot of work with sort of various groups. I think we took much of our lead from England at that point in time.
Well, was Northern Ireland not looking to feed in the impact that there was being felt in Northern Ireland to those discussions?
Yes, and I think they did that through our involvement of the people that went to there, but I'm not sure that there would have been a wider discussion. We obviously were part of the gold and silver command structure. We would have had discussions with trusts, etc. But in terms of specific groups, I'm not aware.
I want to look briefly at some of the comments that were being made by the UK, the Northern Ireland representative on the UK IPC cell. And it's on the 23rd of December, it was at tab 9 of your bundles, INQ 000398242. The individuals stated to say, in the absence of robust evidence to support the move, and then initials are given, felt that colleagues might think that they have not been appropriately protected with what has been previously recommended. Are you aware of what discussions were taking place within PHA in around December 2020 about what the impact might be on the confidence of healthcare workers in Northern Ireland if there wasn't a change of guidance?
I'm not aware of those discussions. I would be aware, because I worked in the trust during that period of time, that there was always a degree of concern that people wanted to use PPE, etc., at a sort of maybe beyond what was recommended. I think you discussed earlier, to the use of FFP3 masks, etc. People may have felt that they give them added protection, but the guidance was you should use them only when you're using GPs, aerosol-generated procedures, etc. People might have thought, well, actually, I should be using that if I'm working in an ED department or not involved in non-aerosol-generated. So I think there was always that concern. I think people were genuinely frightened, and sort of always sought to have a higher level of protection than was sometimes what they thought was being recommended within the guidance.
And what did PHA, as the body with representatives on the UK IPC cell, do to assuage those fears of healthcare workers in Northern Ireland? Did they explain the guidance? Did they provide further information? Did they talk to representatives?
I think through the goal that we would have had discussions each day with trust representatives, or as the pandemic progressed, sort of every sort of number of days through that sort of command structure, in terms of providing the evidence and saying, look, this is the best evidence that we can have confidence in at this point in time, and we have nothing to dissuade us to move away from it.
And did that message pass down to your healthcare workers who were actually on the ward? Because it seems that fear never went away. Was that a fair description of what happened?
I think that fear never went away, whether or not that was because people just had a high degree of anxiety at that point in time, and whether or not you could have ever dissuaded it in terms of that, I don't know.
Well, did PHA do enough to try to assuage it? Or should they have done more?
Probably should have done more, but again, it was a very fast-moving environment as well at that time, and we had a very limited resource in terms of what we could actually put on the ground and where we could have those conversations. And we went back to that. We took that up at the start, that we probably didn't have the number of staff we had, so we had a very small team.
So would that be another lesson learned, effectively, about something that should be done, something that should be thought about within PHA in the event of a future pandemic?
Yes.
Paragraph 91 of the PHA statement says there were no issues in relation to PPE reported to PHA. Is that true?
My understanding is that we never had concerns about the lack of supply of PPE across Northern Ireland. That's the issues that people are referring to.
Right, so that's a very high level. That's Northern Ireland as a whole, yes, rather than individual healthcare workers were saying that they didn't have access to PPE that they needed within their own hospital, GP surgery, pharmacy.
I'm not aware of any reports of people ever saying that they didn't have access to appropriate PPE as advised in the guidance.
Just want to make, are you saying that throughout the whole pandemic there wasn't one report to PHA that people didn't have access to the necessary levels of PPE?
When I've spoken to my team, that's what I've been advised. I don't think there was a supply. I don't think there was ever a major concern of a supply of PPE across Northern Ireland.
Okay.
Can I add? I think there may have been general concerns where people at times felt that they should have been using higher levels of PPE than was recommended. But again, that goes back to that sort of fear issue, I think.
Okay. I also wanted to, if we could, I hadn't flagged this up ahead of time, so I apologise for this. If we could please have on screen INQ 000398219. So this is a IPC cell meeting minutes, and this is at tab 10 of your bundle. And then just want to scroll down to that bottom paragraph, please. So again, that's the individual from Northern Ireland who'd been, I wouldn't say seconded, was a member of the cell. AGP discussions had been had around individual organisations to decide on what an AGP is, which is causing confusion in trusts in Northern Ireland, as some are going with Resus Council guidance over PHE guidance. These additional guidelines are causing ongoing issues. To what extent did the Northern Ireland IPC cell seek to try and bring some clarity about what guidance should be applied?
I think the Northern Ireland IPC cell through the trusts would have advised that we should follow the PHE guidance. I think prior to the pandemic, organisations followed the Resuscitation Council guidance. And as the pandemic progressed, there was much discussion around, well, what is an AGP, and guidance on AGPs and what should be considered an AGP progressed at the time of the pandemic.
Because if we could please go over the page. It's the top line. I'm very hesitant to stray into Module 6 territory around care homes. But again, there's a comment that care homes were refusing to undertake CPR due to this issue. Isn't that exactly the type of thing that the Northern Ireland IPC cell should have been making sure did not happen? That there was absolute clarity that care homes knew that they could undertake CPR?
Sorry, could you say that to me again?
Sure. Isn't that exactly the type of thing that the Northern Ireland IPC cell should make sure was not happening, so that care homes knew that they could undertake CPR?
I think, I know that comment was made when I checked it with the team. They have said, whilst the comment was made about care homes refusing to undertake CPR due to this issue, whilst there may have been a refusal, we don't know that there were any incidences where it was actually not given at all.
But did the Northern Ireland IPC cell make sure that there were no situations in Northern Ireland of people not providing CPR as a result of any potential misunderstanding or lack of clarity in the IPC guidance that applied?
I'm not sure it would have been as specific as that. I think what would have happened was that notification would have been out that the PPE in use was sufficient to meet the needs. And I think CPR later was not considered an aerosol generating procedure.
That doc can come down now, thank you. How did the Northern Ireland IPC cell or Public Health Agency track and assess whether the IPC measures that were being implemented were actually working? Putting it a different way, did they track nosocomial infections to have an understanding about how those were arising?
I think nosocomial infections were tracked through Northern Ireland, but again, we would have had lack of information in sort of the community, etc., and GP surgeries.
But did the IPC cell in Northern Ireland have any understanding of how the various trusts, maybe different hospitals at different times, were applying that guidance, whether they thought that their local risk assessment meant a higher level of IPC protection was needed, or actually whether their level was low, so it wasn't as necessary? Was there any record tracking kept of that?
No.
Why not? Would that not have been useful to understand how the IPC guidance was operating in Northern Ireland?
I think there was an assumption that the IPC guidance was out there, it was being adhered to, and the general sort of tracking of the disease was not sort of significantly different from other parts. But I can see the point you're making. Was it specifically tracked on whether or not the IPC guidance was effective? I don't think it was. Don't believe it was.
Is that not a failing to, as the body sets the guidance, to check to see whether it's actually working or not, and how it's being applied?
Yes.
And again, maybe this isn't something you've given any thought to, but how do you prevent that happening in future? How do you address that situation?
I think in the future, the way the surveillance systems are now being set up, we would have a better understanding of the disease progression at this point in time. So I think they would rely on that. But I don't think any consideration has been given specifically to how you understand so the safeguards put in place are actually effective.
Did the PHA ever provide any advice about visiting restrictions that apply in healthcare settings?
Visiting was sat, I think, as in other nations, with the Chief Nursing Officer for Northern Ireland, but we would have provided advice into her and sat as part of that group. But the decisions around visiting set very clearly with the CNO.
Has there been any analysis done within the PHA about the impact of the visiting restrictions that were put in place and whether actually they were too high, just right, whether they had the effect that they sought?
No, but I think that would have been difficult to do, because I think the visiting was very much impacted upon the type of estate you would have had, so it would be hard to do it on a very general basis as to how the visiting restrictions had an impact. And I think much of it was based on local risk assessment as well. So, two maternity units with two different types of estate may have had different restrictions based on their own local risk assessment.
And to what extent were those local risk assessments being fed back in to show what worked well, what didn't work well in different situations?
I don't know. I'm assuming that would have went into the CNO. I don't think we did any of that.
Okay. Moving now to the role of testing and the role that testing can play. Did the PHA do enough to increase the availability of testing to allow for a greater understanding of those who present to either primary care or particularly hospitals about their COVID status?
Obviously, one of our staff at the time led the expert group on testing, and I think they did quite a bit of work over that period of time. If you look at the guidance, I think there's like 9 iterations of that, and as understanding grew and availability of tests grew and their accuracy grew and confidence grew, I think the guidance was adjusted to reflect that.
Wanted to ask about long COVID. So does PHA have any role in relation to identification of long COVID?
Not that I'm aware of.
And then another corollary of visiting is the use of technology in the provision of services. And this is something that's set out at paragraph 68 to 70 of your statement. Again, there doesn't appear to be any analysis of what went well, what went badly, about use of technology in the provision of services in Northern Ireland. Is that something that the PHA was looking into, has had consideration of?
I think we provided some guidance around the use of sort of virtual visiting, and I think that's in the pack as well, and how that could be used and sort of very practical approaches. Its impact, I don't think, was followed up in terms of analysis of whether or not that could have been improved or not.
Why wasn't it followed up?
Again, I would go back to perhaps we have a small team. There's things that we prioritised during that, and I don't think that was on the ones that we did. And visiting, again, I think sat with the CNO's group as opposed to us.
Okay. So was there any assessment of the impact of those who are living in rural areas to access services?
No, that wouldn't have happened.
Has there been any review done by the PHA of the ongoing use of technology and the provision of services and the impact that has upon health of Northern Ireland?
In terms of visiting or in terms of use of virtual technology overall?
Either way, as far as it falls within the PHA remit.
No, and I don't think it does fall within our remit either.
PHA Deputy Director of Allied Health Professions and Public Involvement was the chair of the HSC COVID Staff Health and Wellbeing Group. Is that right? And that was established in early March 2020. And the role of that group was to provide staff, well, part of the role of that group was to provide staff with support, guidance and advice. And I think there was a website that had been established. Was enough done to provide support for HSC staff during the pandemic?
I don't think was. I think we can reflect back and say that we didn't do enough, and I think it was something which is lacking in our preparedness about how you support, because as you can see, those things were developed after the event and arrival of the pandemic, and that surely should have been something which was in our planning prior to that as to how we support staff through that. I think one of the other things was at the outset, people were hopeful that it was going to be a short-lived thing. No one expected it to go on so long, and therefore the impact upon staff health and well-being wasn't considered, and I think more could have been done.
Just to push back on that slightly, it was anticipated there would be a second wave, I think, in early 2020. Yeah. So knew this wasn't going to be just a one-wave issue.
No, but I think at the very outset, I don't think people thought that it was going to be as long as it did, and when it would have the far-reaching impacts that it did.
And so when that became apparent that it was having those long-lasting, far-reaching impacts, was more done to provide extra support for staff?
I think that group continued to meet and think about it, and the psychological, well, obviously through the PPE, etc., was around physical protection of staff. I think the significant issue around whether or not the mental health of staff was protected was not addressed in the way that it should have been.
Well, I mean, one of the points that's the advice that was given was psychological helplines that were open to staff and within the trust, local GP practices and independent care providers. And I think every trust had its own line that was allowed staff to seek psychological help, that's right?
That is correct.
But again, reading the one that we have in your tab 5 at INQ 000416738, all of those are 9 a.m. to 5 p.m. Monday to Friday. What would a staff member do if they needed help on a weekend?
I suppose the own trust would have had their own access to occupational health during those periods of time as well. And there are other sort of psychological helplines which are out there available to the general public outside those hours.
During a pandemic, could more have been done to make sure that there were psychological services available to health and social care staff?
Yes.
Are there any, apart from the topics that we've covered today, are there any other lessons learned or recommendations that you'd wish Chair to consider?
I think for me, and I think it's come out in the evidence, that there was we did not have enough information flows or give enough due diligence to the impact of pandemics or healthcare disease on people from a black and ethnic minority background, and I think certainly in Northern Ireland that needs to be a focus for us going forward. I think the other thing which we are acutely aware of in Northern Ireland is that we are the only part of the UK with a direct land border with another country, and I think there needs to be a recommendation about how we work as an epidemiological unit as an island going forward. And certainly we are working with the Republic counterparts on maybe an all-Ireland surveillance system.
Just to test you quickly on those two, the second one certainly has quite a large political element to it, is that fair? In terms of Ireland as an epidemiological unit?
I'm not thinking it in terms of politics. I was only thinking about it in terms of health, because one of the things that we are acutely aware of is that it's a very open land border, and that people and disease flows across that without recognition. And yes, I am aware of the politics of that, but purely from a health perspective, in talking to our health colleagues, that would be welcomed. And I think it's certainly in terms of H5N1 and things like that, which might be caused by migrating birds coming across the Atlantic from America. They could land either side of that border, could cause disease, and individuals will travel back and forth.
So is it that within the healthcare system, do as much as you possibly can do, and let the politicians, I think to quote Ms Campbell in a different setting, just get on with it?
I mean, there are examples where we do work very, very well with our counterparts in the Republic of Ireland in terms of health, but I do recognise that there are political decisions which are outside my remit, but in terms of a health service, it sort of makes sense.
Thank you, Mr. Dawson. Well, those are some questions I have.
I think we have some questions. Ms. Freebester, I think you're going first, behind the pillar.
Thank you, my lady.
Dawson.
Mr. Dawson, I represent John's campaign, Care Rights UK and Patients Association. At paragraph 181 of your witness statement, you refer to work undertaken to identify learnings from the pandemic and to identify areas for improvement. And you report that virtual visiting services were found to be successful and valuable in maintaining connections between patients and loved ones. Were you aware, and did PHA consider, that many patients and staff found using or facilitating virtual communications traumatising, particularly around the end of life?
And I think they were difficult around end of life at that point in time, and I appreciate that for families and loved ones who lost people in those circumstances, doing that over the electronic means is very difficult and hard. But I think there were other complexities at that time around IPC, etc., and the protection of other people that might have been in the unit as well.
And was anything done to address those concerns, particularly around end of life, as you say?
I don't think a lot was done. I think there was empathy around it happening, and none of us thought that was a satisfactory way, but I don't think anyone could think of a better way of doing it at that point in time when the disease was expanding.
And has there been any reflection on how it could be done better?
I think it is something that we need to reflect further on when we go through it, but at this point in time, I'm not aware of anything.
Thank you. That's my question, my lady.
Thank you very much. Mr. Wagner, over there, Mr. Dawson.
Thank you. Good afternoon, Mr. Dawson. I ask questions on behalf of the clinically vulnerable families. I first want to ask you about the IPC guidance. Professor Susan Hopkins, who I'm sure you know is the Chief Medical Advisor of the UK Health Security Agency, gave evidence to the inquiry earlier in this module. And one of the things she said was that, in her opinion, the use of air filtration was not given sufficient priority in IPC guidance. And she said that going forward, greater consideration should be given to, for example, to portable HEPA filters. Do you agree with that?
Yes, I do agree with it. I mean, I think even in our office now, we have a portable HEPA filters. I don't think they were in use as much before the pandemic, or people actually gave any great thought to it. But again, there is an issue around sort of the building stock of the NHS, and some have better air handling facilities than others. And it sort of goes back to the age of estate and local estate knowledge of where sort of turnover of air and oxygen within a facility might be. So it'd be hard to do, I think, very sort of high-level guidance that, again, might come down to local risk assessment based on buildings and estate knowledge.
Thank you. Did the Public Health Agency, through the Northern Ireland IPC cell, at any time give or consider giving guidance on IPC measures to be implemented to protect clinically vulnerable or clinically extremely vulnerable patients in healthcare settings? For example, staff wearing FFP3 masks, or indeed patients wearing masks?
I'm not aware of that specifically. If helpful, I can find out and report back to the inquiry.
Thank you. And if that guidance wasn't given, would you agree it does make sense that where there is a relatively high risk to particular patients, that specific guidance is put in place to protect them?
Yes, I do think in terms of IPC, in terms of some of the most vulnerable areas around cancer, that there may have been some discussions on how you protect in that sort of very clinically vulnerable group who might be more immunosuppressed in the normal sort of population in a hospital, but there were some discussions.
Thank you.
Thank you, Mr. Wagner. Mr. Thomas. Behind you, but could you make sure your answers go into the microphone, Mr. Dawson? Please?
Yes, my lady.
So forgive me one moment. Good afternoon, Mr. Dawson. I'm asking questions on behalf of FEMHO, Federation of Ethnic Minority Healthcare Organisations. I want to first turn to limitations on the ethnicity data collection. In paragraph 424 of Sir Michael McBride's statement, he addresses limitations in data collection due to poor coding of ethnicity in healthcare records in Northern Ireland, despite awareness of disproportionate health inequalities. Given Northern Ireland's smaller proportion of ethnic minorities, do you believe that this demographic factor contributed to the oversight in prioritising ethnicity data?
Yes. Yes. As I said previously, I don't think we served that population well in terms of our data and our data collection. And I agree with you. I think the size of the population, I know we discussed that earlier, did probably lead to an oversight in that area, or it wasn't given the focus, I think I said, as it should have been.
Okay, well, given that, what strategies would you suggest to prevent similar data limitations in the future if we have another public health crisis, to ensure that all communities are represented accurately?
Well, firstly, I think the strategy in terms of information data is led by the department, and I'm not going to step away from that, but my understanding is through, and we have had these discussions, our new digital Encompass project, that sort of trust data and ethnicity will be much better, and there are single sort of ways which data can be entered in, and I think going back, it sort of like the field safe that you have to record ethnicity. So I do think there's a strategy now going forward to have better data across all the range of information relating to our population that we haven't had previously. But that strategy sits, I think, with the Department of Health. Although we're a significant user, we would wish to see that as well.
Both you, so I'm now moving on, I'm looking at intersection between social deprivation and ethnicity and in health inequalities. Now, both you and Sir McBride discuss the significant role of social deprivation in health inequalities exacerbated by the pandemic. In Northern Ireland, where ethnicity data remains poorly coded, there exists a critical intersection between social deprivation and ethnicity that may not be fully understood or addressed. So moving forward, how do you propose that this intersection could be better incorporated into data practices?
Again, we are developing our new corporate plan, and I think it's one of the things that we would focus on is people from sort of a wider or diverse range of ethnicity. In terms of where we would want to see better data is obviously we'll get that from the hospitals, but as identified earlier, the data owner for GP practices remains with the GPs. And I would like more access into that information, because that will give you a better basis of the whole population, not just those which end up in our healthcare trusts. We already have good data in terms of our child health system, but that obviously only runs to a certain age.
Thank you. Millie, those are my questions.
Thank you very much, Mr. Thomas. Samantha Jones for this bit. There we are. Behind you to your right.
Your council covered one of our questions pretty adequately, pretty well. I wondered if I could ask for permission to ask one follow-up question on the corporate plan that Mr. Dawson has mentioned a number of times. I'll keep to my 3 minutes.
All right.
Thank you very much. Mr. Dawson, thank you. So just to clarify an answer earlier that you gave to counsel to the inquiry, you said and accepted that there was very poor data on disability kept by the PHA during the pandemic. Can I just clarify, was any mortality data on disabled people kept by the PHA during the pandemic?
Not that I'm aware of, but I can't sort of say that for certain, so I'd be happy to come back on that.
Thank you. And then my additional question, on the corporate plan that you've mentioned a number of times in your evidence today, could you just help us with when that corporate plan will be finalised in its drafting and when it will be implemented by the PHA?
Well, our aim at this point in time is to go to consultation in December, and then that's a public consultation. Final draft should go to the agency board in March with its implementation from April going forward.
Thank you. My final question then is in relation to paragraph 161 of your statement, and there you outline several different sources of death data, and that was in respect of the ways that the death data was collected. I don't want to take you to it. In respect of that, can you explain whether any of those sources of that death data collected data on whether someone had a disability?
Again, I don't know if disability is recorded on that. Again, I could come back if any of those are very clear. As to say, we don't have a statutory responsibility. That sits with NISNA and the GRO in terms of the information which is collected around deaths.
Thank you very much. Those are my questions.
Thank you very much, Ms Jones. And Ms Campbell. Ms Campbell's there.
Mr Dawson, thank you. My name is Brenda Campbell and I represent the Northern Ireland COVID Bereaved Families for Justice. Can I take you back, please, to the topic of testing? And in fact, all of my questions will focus on testing. And just to give it some context, we know that as at the 23rd of January 2020, so we're looking at a very early stage in the pandemic, the Public Health Agency had established the Emergency Operations Centre. We know that shortly thereafter, the agency was asked to lead departmental initiatives around testing, and particularly the expert advisory group on testing. And we know from paragraph 95 of your statement that there then began some 9 iterations of guidance issued by the PHA, but in conjunction with the department, on testing, the first of which was on the 19th of March 2020. And that focused, it's behind tab 11 in your bundle, it focused on testing of healthcare workers and patients in hospital settings.
Yes.
And just for the inquiry's reference, the INQ number is 000120705. It's that 19th of March guidance that I'd like to ask you some questions about. It was 3 pages long, and to give it some context, the later guidance was towards the end of the guidance were as many as 25 pages long. And it focused on the testing of some symptomatic patients in hospital and some healthcare workers in certain frontline duties, starting at surgeons and physicians. It didn't address anything about testing on hospital discharge into other care facilities. It didn't address anything about testing in, for example, non-hospital care settings or care homes. In relation to those issues, wider groups of testing, do you know whether they were on the PHA's radar at the time?
I'm not sure that they were on PHA's radar at that time. I think the greater focus at that time was around capacity within those secondary care settings to deal with people with illness. So I'm not sure that they were, but again, I wasn't there, and that's not something which I think is covered within the documents that you're referring to, therefore, but I'm happy to go back and check as to what consideration was given to that, if helpful.
You see, by the 19th of March, and again, this inquiry has heard much in terms of context, we had been long witnessing what had been happening in other parts of Europe. We were the best part of a month after Northern Ireland's first positive case. We were a week after Northern Ireland had in fact suspended community test and trace And it was very shortly before relatives of at least 2 of our client group had passed away, both having contracted the virus in the same Belfast hospital. Do you, as an agency, understand the concerns on the part of the Northern Ireland COVID bereaved that there appears to have been, even at that very early stage, a failure on the part of the Public Health Agency to identify the importance of widespread testing of healthcare workers and patients in various settings?
I accept that, yes.
And do you agree that what appears to be some last-minute scrambling to produce a 3-page guidance of the nature that you'll have looked at in preparation for your evidence from the perspective of the Northern Ireland COVID bereaved is inadequate?
I think it is inadequate. Again, as we said at this point in time, I wasn't there. And whether or not those who felt at the time it was adequate or it met the needs, I don't know what pressures they were under or what information they had in front of them or for what purposes it was intended to be produced at that point in time and what their driving factors were. Like you, I have read the guidance, but some of that information behind that I'm not aware of.
Well, picking up on that answer, and in fact some of the questions that you were posed by Mr. Scott at an early stage, given that you weren't there and you're not aware of what impacted that guidance at the time, has there been any reflection in the Public Health Agency about gaps and missed opportunities at that very early stage?
I think it's fair to say no, that we haven't. I think that was probably picked up as we went on, and the further guidance that would have been more reflected in further guidance as it came out during the progress of the pandemic. More as it happened as opposed to retrospect now. Well,
looking then at what happened at later stages in the pandemic and actually coming to a point in time in which I think you took up your post, although I'll be corrected if I'm wrong, can we move in time then to summer into autumn 2021, July in particular? At paragraph 102 of your statement, you tell us about the expert advisory group drafting a paper in relation to testing support in relation to hospital visiting.
Yes.
And that paper concluded that testing of visitors should be used in addition to other mitigations such as PPE, and it observed that there was no consistent approach across the UK, having done some analysis. The paper, and again for the inquiry's reference, it's at your tab 15, INQ 000343958. Again, it's a 3-page document. And within it, it observes that individuals from within the Northern Ireland testing team had met with officials from NHS England in January, so 6 months previously. And at that time in January, NHS England had offered testing to visitors to maternity settings and to end-of-life care as a means to facilitate visits at those very important times. This document that's discussing those visits is dated July 2021, so 6 months on from those discussions. And you go on in your statement to indicate that it wasn't until September 2021 that the CMO issued a letter outlining then the availability of lateral flow tests to support visiting in hospital settings. Again, can you understand the concern of the Northern Irish COVID bereaved, many of whom were denied access to their loved ones, that there was a failure to appreciate the detrimental impact of those restrictions on visiting at an early or a rapid enough stage?
Yes, I can understand that.
And can you understand why that chronology of January to July to September gives the impression that there was a lack of urgency or understanding in the PHA which was leading on this in relation to both the plight of patients and their loved ones?
Yes, I can understand that. Again, it's not a discussion I've had with that team, so it's hard for me to understand what their considerations or things that were going through their head as to why that took that period of time. But I do understand that is seen as a lack of timeliness on our part.
Well, can you also understand why the Northern Ireland COVID bereaved might be still concerned that you haven't had those discussions with those teams, and that again there appears to be a lack of reflection and therefore identification of areas of improvement going forward?
Yes, I can.
And what's going to change?
I think as I leave today, I will discuss that with our team as to how we are better prepared to reflect on the things that have happened during the COVID period of COVID.
Thank you.
Thank you, Ms Campbell. Ms Inga, I hope you're not going to get me into trouble today.
My lady, no. Mr Dawson, I appear on behalf of the long COVID groups, and I have some questions on the response to long COVID in Northern Ireland. You've said to Mr Scott that data on staff deaths and staff illness wasn't recorded with reference to the spreadsheet in tab 3. To confirm, does it follow then that the Public Health Agency wasn't collecting data on the number of healthcare staff with long COVID?
No, it hasn't, that I'm aware of.
So there wasn't and still isn't a clear picture of the harm long COVID causes to healthcare staff?
That is correct.
Do you agree that it's necessary to bridge that data gap so that healthcare workers can be better protected from long-term harm?
Yes.
And finally, Mr Dawson, you've been asked some questions about the steps the Public Health Agency took to support staff health and well-being. And quite some detail in your statement is provided on that, paragraph 72 to 84. Did the Public Health Agency take any steps to support the health and well-being of healthcare staff with long COVID?
As I said here, not that I'm specifically aware of, but again, I'm quite content to discuss that with the team and address that going forward and come back to the inquiry, ma'am.
Do you know why the impact of long COVID on healthcare staff was overlooked?
No, I don't.
Thank you. My lady, I'm grateful.
Thank you very much for your help. Thank you very much, Mr Dawson. I appreciate it. Can't have been easy answering questions before you were in post, but obviously you've done your best. Thank you for your help.
Thank you.
I shall return at, I've got one or two things extra to do. I'll return at 10:02.
All rise.